So we're gonna kind of go into talk about co-occurring substance use disorders and mental illness. Just an overarching introduction and introducing some basic principles of it. No disclosures either in the past or currently. What are some of the objectives? Well, we'll first some of the main things I want to highlight are appreciating how to start to even differentiate between a substance-induced psychiatric illness versus an independent primary psychiatric illness. We'll go a little bit into the comorbidity between substance use disorders and various psychiatric illnesses and start to talk about the basics of a treatment approach for individuals who may have these dual diagnoses. So starting with some definitions, starting with some epidemiology. So this is data from SAMHSA coming from just a couple of years ago. So here it's showing, right? So if you kind of think about it, this is looking at past year prevalence of various illnesses. So the big red circle are individuals who had mental illness. The yellow circle is individuals who had any substance use disorder in the past year. And the orange oval is the overlap between the two. So if you think about it, in the United States, about 19 million individuals with a substance use disorders in the past year, and 8 million of them, in other words, about 40% of those individuals also had a co-occurring mental illness. So pretty high proportion, right? And I can tell you from experience that at a clinic such as the one that where Dr. Jacobson, Dr. Maley and I work at University of New Mexico's Addictions and Substance Abuse programs, that number is even higher. That number for us is about 70%. And many of you who are sort of frontline providers, treatment providers, probably have a similar experience. So the take-home point here being that substance use disorders do not happen in isolation. Very often, there is a concurrent mental illness. And nationally, in at least roughly 40% of those cases, we see that. Now, this one is looking at what's called a serious mental illness. And again, you can see that, if you think about all individuals with mental illnesses, now focusing on that red circle, about 10 million individuals in the United States met criteria for a past year serious mental illness. And about 2.5 million of them, or about 25% of them, also had a co-occurring substance use disorder. So basically, kind of simplifying things a little bit, and I thank Dr. Paul Romo for this slide. He kind of went through the data and pulled together these 3 bullets, that having any substance use disorder increases the odds ratio for any sort of what in DSM-4 was termed Axis 1 diagnosis, right? And any Axis 1 diagnosis increases the odds ratio for having a substance use disorder, and having a substance use disorder increases the odds ratio for another SUD. So all these things happen together: mental illnesses, substance use disorders, and having one makes it more likely that the individual may also have additional illnesses. These are just some more data looking into it. That if you look at all individuals with substance use disorders, they're about 4.5 times more likely to suffer from a comorbid psychiatric condition, mental illness. Individuals with a psychiatric illness, similarly, are about 4.5 times more likely than the general population to also have a substance use disorder. And this one is looking here from a study from 2016. Looking at really a large proportion of individuals, almost 500,000 people. And they found, and it's looking at any lifetime substance use disorder broken down by a number of psychiatric illnesses. So you can see that, for example, with something like schizophrenia, if an individual has schizophrenia, about 37% of those individuals will meet criteria for a substance use disorder at any point in their lives. And you can see similarly elevated rates for a number of other psychiatric illnesses, right? And so what's the substance that's the most common? Perhaps unsurprisingly, it's alcohol, followed by other substances. So why should we care? Why does it matter if an individual has these concurrent illnesses, concurrent disorders? So this is a slide, again, coming from a paper in 2016, looking at if someone has just a serious mental illness versus just an SUD, compared to those individuals, if someone has a dual diagnosis, in other words, the combination of a substance use disorder and a mental illness, that individual is likely to have all of these outcomes. more psychiatric hospitalizations, higher relapses of the psychiatric illness, increased number of suicide attempts, violent behavior, criminality, imprisonment, family problems, loss of social status, poorer quality of life, greater medical comorbidity, HIV infection, higher rates of unemployment, homelessness, poor treatment adherence, as well as therapeutic failure. Therefore, it's critical for us to treat both of these illnesses together versus just treating one or the other, right? Because outcomes, if diagnoses, tend to be much worse compared to having just a substance use disorder or just another mental illness, right? So with that background, let's kind of go into some principles of patient care. The first step, of course, is assessment. And when we talk about assessment, the first and overarching question always is there a psychiatric illness? And if so, is it substance induced? In other words, it's caused by the use of or withdrawal from a substance, or is it a primary underlying psychiatric illness? That's often sort of the first determination we as clinicians are making. So let's talk about that for a couple of minutes. First, starting with if you see a patient who is acutely intoxicated. This happens, for example, for those of us who work at our psychiatric emergency services, quite a bit where a patient comes in, there is acute intoxication, right? Of course, what we're working on there is those emergent things, screening for suicidality, screening for homicidality, screening for physical safety, right? By reviewing vital signs, oxygen saturation, etc. And what we want to do is attend to medical symptoms or withdrawal management. That takes priority in an acutely intoxicated patient. What we don't recommend is to continue or proceed with a probing psychiatric evaluation in an intoxicated patient. Rather, it's best to wait until sober. May sound intuitive, may sound obvious, but I think it's an important point to make, that it's very hard to diagnose an underlying psychiatric illness in an individual who is acutely intoxicated. And what we really want to focus on is the immediate safety of that individual. So with that caveat out of the way, let's talk about the independent psychiatric illness versus the substance-induced psychiatric illness. How do we distinguish it? So substance-induced disorders, when we think about those, generally what you see is that symptoms occur only when misusing the drugs or the substances, right? And the symptoms are related to intoxication, withdrawal, or other aspects of active use. Maybe it's related to sort of the guilt that comes from the consequences of the use when the intoxication wears off, for example. We also see that onset and offset of symptoms, as well as worsening and improvement in symptoms, kind of follow or mimic increases or decreases in substance use. So the goals for these patients in general, in overarching terms, are to get them into sustained abstinence, sustained remission, and then reevaluate the psychiatric symptoms. By contrast, independent disorders, what you see is that symptoms occur even when an individual is not using or misusing psychoactive substances, right? Or even when the use stays stable. Family history may be a clue to an independent disorder. For example, if someone's presenting with meth use disorder and psychosis, and if there's a strong history of psychotic illness in a first-degree relative, my alarm might go off that this may actually be an independent psychotic illness, right? That's kind of what I'm getting at there. The goal here is going to be cessation of substance use, but also treating the psychiatric symptoms. Because if the independent psychiatric illness is present, just getting someone into remission, just helping the person cease or reduce their substance use is unlikely to treat their psychiatric symptoms. And the best practice would indicate that we have to treat the underlying psychiatric disorder in these patients. So some basic pearls. I think there are three components of the history taking that might help us distinguish between these two. One is, as I mentioned, the family history. And I'll give a concrete example. Recently, we've been working with a patient at our clinic. For a long time in the chart, there is this, it's been mentioned that the patient has stimulant use induced psychotic history. However, when one of our trainees actually did a very thorough psychiatric history with this patient, the trainee learned that there is a very strong family history of schizophrenia in this patient. And then when they dug into, so that was sort of the first clue that maybe this isn't just substance induced, but maybe there is underlying primary psychotic history. And then some of the other clues in that particular history actually presented by initial symptom onset, where the patient actually reported sort of this prodrome, this period of worsening delusions, as well as social detachment, not taking care of herself. And this happened from collateral information even prior to the patient began to use stimulants, right? So that's another clue that, well, if the symptoms began before the use of the substance began, then maybe this is again a primary underlying psychotic illness. And the final thing that we clue in on is what happens during periods of abstinence or reductions in use. And very often what you see is that patients who have that primary underlying psychiatric illness will say, things were horrible when I wasn't using, right? I wasn't using, but I was checking under my bed every night, and I had to make sure that the door is locked every evening 6, 7, 8 times. And in fact, that's one of the reasons why I returned to using the substance, because things were just so uncomfortable. That to me points towards the underlying psychiatric illness, versus the patient who tells me things were great when I wasn't using. I had a job, I was able to complete my probation, things were going really well, where it might point us towards substance-induced psychiatric illness. And then finally, the second big thing is, as you begin to treat that substance use disorder, observe what happens. And as many people who are sort of experienced at treating opioid use disorders using our FDA-approved pharmacotherapies such as buprenorphine will tell you, it's pretty easy to get someone's acute symptoms of opioid use disorder, including those withdrawals and cravings, and under control pretty quickly with buprenorphine, right? If someone comes to you, as we've talked about before, seeking treatment for opioid use disorder, you can actually get them started on buprenorphine and within a few days have them feeling a lot more comfortable. And at that point, you can really evaluate the patient further and see what's happening to their depression or anxiety, for example. And then if the symptoms are persisting beyond that acute stabilization, it would be appropriate to provide treatment for those, right? And this is just a little, again, from the same paper that I've cited a couple of times. This is just sort of some distinguishing criteria for reference for your review that you can sort of turn to later if needed. Here, what I've done, again, going with sort of provide a reference, because I know all of you received these slides, is that I've taken a couple of slides here, actually about 5 slides. I'm not planning to go through this slide by slide in great detail, but what I was thinking about what would be really helpful to provide to the participants, right? When we talk about assessment of patients who may have co-occurring SUDs and mental illnesses. Often the questions we get when we do consultations is, well, it's really hard to tell whether these symptoms are happening as a result of a substance intoxication or withdrawal, or whether it's a result of an underlying psychiatric illness, because there is quite a bit of overlap. So what I did here was went through a number of common symptoms, common substances rather, broke it down by intoxication and withdrawal. And then I've included text in red letters and blue letters. And red letters are symptoms that you might see, right, that might be a result of the substance or the psychiatric illness, right? So it doesn't really tell us much. But then in blue letters are the symptoms and signs and symptoms I've listed that don't necessarily happen from a mental illness, but may happen from that particular substance intoxication or withdrawal to help distinguish. So I'll just use alcohol as an example, right? To hopefully clarify this a little bit further. So during alcohol intoxication, you can see mood lability, aggressive behavior, inappropriate behavior, impaired judgment, impaired attention, impaired functioning. So the question arises, is this a result of alcohol intoxication, or is it a result of, for example, an acute manic episode? Just those symptoms don't tell us a whole lot. But then when you look at some of the things listed in blue, slurred speech, incoordination, unsteady gait, nystagmus, impaired memory, or even stupor or coma, for example, in extreme cases, well, if you see those things, it's much more likely a result of alcohol intoxication as opposed to acute manic episode, where you're unlikely to see those things, right? So those things in blue may help us distinguish. Similarly, with alcohol withdrawal, you might see things like anxiety or insomnia or agitation, auditory hallucinations even. We don't know if it's a result of alcohol withdrawal, whether it's a result of an underlying psychiatric illness. But in blue are the things that you see with alcohol withdrawal, which if you notice them, would really tell us that this is substance induced as a result of alcohol withdrawal, and that's what we should be treating. Things like autonomic hyperreactivity, elevated blood pressure, elevated pulse, tremor, nausea or vomiting, visual or tactile hallucinations, seizures, delirium, right? Those things, if you see them, would strongly point towards alcohol withdrawal syndrome as opposed to an underlying psychiatric illness, even if you do see anxiety or insomnia with it, right? So hopefully that clarifies it a little bit. Similarly, I've listed for our common stimulants, including cocaine and amphetamine, cannabis, opioids, as well as nicotine. That's there for reference that you guys can turn to at a later time. Just gonna check on the time here really quickly. Good, it's about 12:18, so we're doing okay with time. And now that we've talked about assessment a little bit, let's switch gears and talk about some basic treatment considerations when you're working with an individual who may have co-occurring psychiatric illnesses as well as substance use disorders. This slide comes directly from Dr. Paul Romo, one of our colleagues and contributors to the Echo Clinic. He likes to make this analogy that when you have an individual with dual diagnoses, for example, opioid use disorder along with depression, you want to treat both concurrently, right? If you just treat one or the other, you are not helping the patient. And he uses this example of a ship that has two holes in it. And unless you try to plug both holes at once, the ship will still sink, right? Sounds obvious, but historically, this has not always happened. The previous thought often was at least 6 months of sobriety was required. And even I've seen this in my 10 years of doing psychiatry, 10, 11 years of doing psychiatry, where oftentimes the patient would be told, you gotta be at least 6 months sober, at least 6 months abstinent for that matter, before we can really appropriately treat your psychiatric illness. And that didn't really help, right? Because it was very hard if there was an underlying psychiatric illness present for the patient to achieve that complete abstinence remission for that amount of time. So then it was revised at some point to 1 month. However, now what ASAM, which is American Society of Addiction Medicine, tells you, along with a number of other experts in the field, is that there is no minimum length. As soon as you know that a primary independent illness is present, maybe it's from the history, maybe it's from early stabilization of the substance use disorder, start providing treatment as soon as you know, because when you treat both concurrently, outcomes improve. A classic example of this dilemma in our treatment community comes around the issue of co-occurring post-traumatic stress disorder and substance use disorders. As many of you who are clinicians know, right, from your experiences from reading the literature, PTSD and substance use disorders often happen at very high rates. And studies consistently show that when an individual has co-occurring post-traumatic stress disorder and substance use disorder, in vast majority of cases, the PTSD comes first. And then substance use disorder develops later, almost as a way of coping with it, on the part of the individual, right? But again, historically, what would happen is that if this person went to see a therapist for PTSD treatment, they would be told, well, stop drinking for at least 6 months before we can provide the therapy for this. Because if we provide therapy now, things are gonna get worse. You may not be able to handle it and you might relapse. And if they would go and see someone for their help with their drinking, for example, the person would be told, let's take care of your PTSD first before we really get into addressing the drinking, right? Because if we're gonna be treating drinking, that's gotta be the sole focus, and anything else is avoidance, right? So this would happen, and studies have been consistent that when you provide this kind of a disjointed care, outcomes really worsen, versus treating both concurrently really seems to improve the outcomes. So we've started moving toward this a lot over the last decade, but I just wanted to use that example because that's been the classic example used when we talk about this. Also keep in mind that substance use does not equal a substance use disorder. And if to diagnose someone with substance use disorder, you must assess whether DSM-5 diagnostic criteria are met for that substance use disorder, right? So keep that in mind. I bring it up because oftentimes, again, when I do consultations, I see in the history, someone has taken, for example, cannabis on occasion, and cannabis use disorder gets added to their diagnosis list. And then when you do a full diagnostic criteria evaluation, that may not be present. So basic steps to treatment. I think for these individuals with co-occurring illnesses, don't forget the role of psychotherapy. I said a couple of times that I think as soon as you know that concurrent illnesses are present, start providing treatment. And treatment very often does include psychotherapy. In fact, some individuals will suggest that it should be considered a first-line treatment in patients with SUD, as well as sort of less severe depression or anxiety disorder. And then moving on to pharmacotherapy. Again, to start that pharmacotherapy, at the very least, you want to wait until acute intoxication is gone, acute withdrawal syndrome has been treated, right? So basically, once the acuteness has been stabilized, then it's okay to start treating. And maybe a first line for patients with more severe symptoms, or for diagnoses such as schizophrenia or bipolar spectrum illnesses, for example. In general, what we see is that depression and anxiety are relatively common at treatment entry with people with SUD, but symptoms generally tend to resolve within days of stable treatment. But if symptoms persist, again, okay to treat. This is an important point. I put it in bold lettering, that patients treated with medication-assisted treatments, pharmacotherapy for opioid use disorders, respond to medications for depression and anxiety at rates that are similar to those who do not have opioid use disorders. So our medications for depression, anxiety work just as well, whether or not the patient is on buprenorphine, for example. And generally in this population, you want to avoid medications with addictive potential, such as benzodiazepines or stimulants, but not an absolute contraindication. And if you do start those medications that may have potential for misuse or addiction, or you do want to monitor these patients very carefully. This is just a basic guide for primary care, some medication recommendations for a variety of conditions, and I've included that for reference. And I kind of end here, looking at the time here, good, with sort of a somber note, right? Again, kind of highlighting the need for this integrated treatment. So this, again, coming from SAMHSA, substance use treatment in the past year among adults 18 and older with concurrent illnesses. So over half of them, just over half in 2016, received no treatment at all, whether for their SUD or whether for their underlying psychiatric illness. Another about 38% received mental health services only with no attention to their co-occurring substance use disorder, right? About 3%, so pretty rare, but about 3% received SUD treatment only with no treatment for their mental illness, right? And only about 7% actually received concurrent treatment. So huge gap in services there, right? For individuals with SMI, a little bit less dramatic, but still only 12% of individuals, the red piece of the pie, actually received treatment for both concurrently. So again, even with individuals with serious mental illness and co-occurring substance use disorder, I think there is a long way for us to go. And so this really, I think what the point that we want to make, or the pitch we want to make as much as possible, is to take this integrated approach. An integrated approach is different from sequential care, which says that you treat them in sequence. So for example, in the PTSD example I used earlier, you treat the PTSD, or you treat the alcoholism first, and then you treat the PTSD, right? That's sort of this sequential model, which again, data says doesn't work all that well. Parallel model means that you're treating both together at the same time with little interaction between those. So there's a group of providers that's treating the alcohol use disorder and a group of providers that's treating the PTSD, but they're not really not working with each other. But what SAMHSA really supports, right, is this integrated treatment approach to treating co-occurring mental and substance use disorder, which is client-centered. Patients' goals are taken into account. And I bring that up because very often we fall into this idea that total abstinence, for example, is the only way to go. And that may not be the patient's goal. And if we insist that that's the only way we'll work with you, we risk losing the patient. And outcomes, as I mentioned in just about every presentation I do, kind of really nosedive when patients leave treatment. So we want to work with the patient, see what their goals are, and come up with the best treatment plan that honors those goals. And all disciplines should be collaborating. And that's one of the reasons why this Echo Clinic is so wonderful, because we actually do have So many disciplines represented amongst you guys, the participants. And we know that integrated treatments are associated with lower costs as well as improved outcomes, reduced substance use, improved psychiatric symptoms and functioning, decreased hospitalization, increased housing stability, fewer arrests, as well as improved quality of life have all been associated with integrated treatment. Of course, it can be difficult to come by with limited resources, but when possible, this is the approach we want to be taking. So I will end here. Gonna